Pathogenesis. To be satisfactory, a theory must explain A, the predominance of movable kidney in woman, B, the frequency with which it occurs on the right side, and C, its importance between the ages of 20 and 40. We shall consider A, causes of congenital nephrotosis, B, causes of acquired nephrotosis, primary predisposing cause, shape of the lumbar recess, secondary predisposing cause, enterotosis, pregnancy, emaciation, exciting causes, corsets, trauma. A, causes of congenital nephrotosis. The existence of congenital nephrotosis has been doubted, but the possibility of such a condition is proved by such cases as Dr. W.R. Stewart's. In this case, an exploratory operation performed for intestinal obstruction on an infant 8 months old disclosed a floating kidney. Apt and Morris have collected similar cases. Yet the discovery of a movable kidney in a child is undoubtedly exceptional, and the occurrence of any symptoms before puberty is rarer still. With our present knowledge, it is impossible to say what may be the cause of this condition. It has not been determined how far the factors that operate in later life are at work and how great a part actual abnormal development plays. Coffey, however, states that a unilateral right movable kidney is almost never seen except in cases where there has been a deficient peritoneal fusion of the ascending colon and mesocolon with the parietal peritoneum in front of the kidney. B, causes of acquired nephrotosis. Primary predisposing cause. Wolkow and Delitzin have shown by an extensive series of pathological investigations that there is quite a wide variation in the size of the niche in the loin occupied by the kidney. The paravertebral niche, as they call it, is shallower in women than in men, shallower on the right side than on the left. The feminine peculiarity appears with the broadening of the pelvis at the advent of puberty, and it is this feminine right-sided shallowness of the bed in which the kidney lies that is the chief predisposing cause of nephrotosis. Harris has gone even further and maintains that the chief characteristics of the body form that predispose to nephrotosis, quote, are a marked contraction of the middle zone of the body with a diminution in the capacity of this portion of the body cavity. This diminution in the capacity of the middle zone depresses the kidney so that the constricted outlet of the zone comes above the center of the organ, and all acts such as coughing, straining, lifting, flexions of the body, etc., which tend to adduct the lower ribs, press on the upper pole of the kidney, and crowd it still farther downward. It is the long continued repetition in a suitable body form of these influences, which collectively may be called internal traumata, that gradually produces a movable kidney, end quote. Secondary predisposing causes. The internal traumata just mentioned, and many others, such as intermittent renal congestion during menstruation, prolapse, and inflammation of the pelvic organs, etc., may be included here. But we need discuss only 4 alleged causes, viz. Enteroptosis, weakness of the abdominal wall, pregnancy, and emaciation. Enterotosis is a general condition of which nephrotosis is often one of the features. Glenard considers that nephrotosis never exists without a general enterotosis, but he stands alone in this opinion. Einhorn has seen 27 cases of enterotosis without nephrotosis and 213 cases in which both conditions existed. Hepatotosis occurred with nephrotosis only 30 times, 54 times without it, while in 57 cases, only the kidney was movable. Similarly, Goddard Danhue records 131 cases of nephrotosis without enterotosis and 81 cases with it, while in 97 instances there was enterotosis without nephrotosis. Modern radiography has, however, shown colotosis to be much more common than had been supposed, and the tendency is once again to attach nephrotosis to general enterotosis by means of the nephrocolic ligament, a band leading from the hepatic flexure to the lower pole of the right kidney. Pregnancy introduces another dispute. It is an accepted fact that repeated pregnancies favor relaxation of the abdominal wall and enterotosis. Yet there is an absolute disagreement in the statistics on nephrotosis. Landau, Senator, Mullen, Morris, and others maintain that movable kidney is more frequent in women who have borne children, while Kuttner, Goddard-Danhue, and Lindner defend the opposite theory. Weakness of the abdominal wall, Wolkow and Delitzin insist, is a strong predisposing factor in enterotosis and nephrotosis. The abdominal viscera are deprived of their necessary support and therefore sag downward, carrying the kidneys with them, in case the shallowness of the paravertebral niches makes these organs liable to prolapse. Emaciation, it is stated, causes nephrotosis by absorption of the perirenal fat. Morris has often noted the small quantity of fat that surrounds kidneys requiring nephroorrhaphy. Yet one can scarcely believe that the absorption of fat could be so sudden as to leave a space into which the kidney would sag. On the other hand, it is quite conceivable that the excursions of a movable kidney should discourage the deposition of fat within its fascial envelope. Exciting causes. Corsets have been alternately praised and condemned. A corset that brings pressure to bear below the kidney region will, if applied while the kidney is in place, help to retain a movable organ, while a long-waisted corset that compresses the ribs is equally likely to encourage renal mobility. The fact that Egyptians suffer from movable kidney is evidence that the corset does not deserve all the blame which has been heaped upon it. Yet it does weaken the abdominal wall and so increases the liability to nephrotosis. Position is justly blamed by Cabot and Brown, who maintain that the drooping, flat-chested, round-shouldered attitude compresses the lower ribs and is the occasion of many cases of renal mobility. Trauma of one sort or another is certainly the exciting cause of all cases of movable kidney, but it is equally certain that the trauma in question is usually of a mild type. Suckling mentions the influence of constant stooping. The internal traumata recognized by Harris have been enumerated. The influence of pregnancy and corsets has already been mentioned. Bergman insists upon the evil effect of horseback riding. The effect of acute trauma, such as falls, kicks, and blows, is an open question. Harris absolutely denies its influence, and though many acute cases from this cause have been enumerated, I believe that in most instances the trauma has been only the cause of symptoms in an organ already movable. Secondary changes. As a result of long-continued mobility, the renal vessels may become considerably lengthened. They are the radii of the circle in which the kidney moves. As they lengthen, mobility increases. The ureter may become kinked, and in this event, which is by no means uncommon, the free outflow of urine is obstructed, renal colic ensues, and the kidney becomes inflamed or hydronephrotic. Adhesions may form as a result of repeated attacks of hydronephrosis or of other inflammation of the kidney itself or of surrounding tissues. Such adhesions increase the ureteral obstruction. The kidney itself may be misshapen through pressure or inflamed or hydronephrotic. Exceptionally, gangrene of the kidney has occurred from torsion of the pedicle.